Okay, I want to welcome Dr. Milivanovic from the Misericordia Community Hospital. Dr. Milivanovic is a internist intensivist, ultrasound extraordinaire, and he has just joined the Misericordia group, doing ICU there in internal medicine. So I want to welcome him today. He'll be talking about jumping into the deep end, fluid responsiveness, and tolerance in critically ill patients, a very topical subject which pops up on papers and social media. Yeah, so let's give him a round of applause and welcome Laz.
So I guess I'll get started. For those of you who want to participate in these rounds, you can go to menti.com and use the code at the top of the screen here. We'll just do some basic screening questions to start and just kind of get a sense of where everyone's at with their knowledge from fluid responsiveness and fluid tolerance. And so this is just an open-ended question. This is anonymous. Take some time and respond as to how you would define this and what you think it is. We're getting some answers here, and the answers are ranging from very specific, a 10% increase in systolic or stroke volume with 600 cc's, presumably of crystalloid, to things as defined as improved hemodynamics with fluid or improved parameters after receiving a fluid bolus. And the definition of fluid responsiveness actually is a very, well, there we got one more, sorry, there. Improved substrate delivery in response to volume administration. And so fluid responsiveness actually is a very specific definition that's been used in the literature for this. We can talk about the validity of what someone being fluid responsive is, but for the purpose of how things have been defined in the literature and how we look at ICU level patients, it's defined as an increase in stroke volume of 10 to 15% after a 500 cc crystalloid bolus. It does not measure the patient's current volume status. It is a dynamic measure that changes over time. And so now moving on to defining fluid tolerance. So if you want to take a moment and just enter in what you think or how you would define fluid tolerance for ICU patients. This is all anonymous. The goal is really just to get everyone thinking and talking about this effects. Any other thoughts or people want to answer? Okay, so again, this is a very unique definition in the literature, and it's very close to what was described. And there's various wordings for this, but ultimately it's some wording of the degree to which someone can tolerate a fluid bolus without organ dysfunction. And organ dysfunction, we refer to pulmonary edema, renal failure, elevated left atrial pressures, and signs of volume overload that cause end organ dysfunction. Again, it is not a measure of the patient's current volume status, and it is a dynamic measure that changes over time as fluid is administered. Okay, moving on to the IVC. This has been a controversial topic in the ICU in the literature. And the most common question I get asked when I do a point of care scan is, what is the IVC doing? And what does that mean for us? And so if you want to take a moment to answer how you interpret the IVC in your assessments. And what does that mean as well? So someone mentioned you looking at size and collapsibility with inspiration. What do you use it for? Do you use it for assessing volume status, fluid responsiveness, fluid tolerance? Is there anything you do with it? Is it a surrogate marker for anything for you? How do you interpret the information you gather, and what information do you gather? If small and collapsible, very helpful to determine fluid responsiveness, otherwise variable depending on clinical examination. A very well-worded response. Does anyone else have any thoughts they want to put down here? And we will go over all this during the presentation, so this is just to get a sense of where people are at. And then finally, I've opted not to talk at length about the IVC here. We'll address it in the presentation. And the final question I have for all of you is, what's your experience with Vexus? And saying none is an appropriate answer here. Minimal. None. None. Okay. Sounds fancy. It is fancy. So we are now going to jump into the presentation. So as all of you know, my name is Laz. I'm one of the intensivists at the MIS and Grey Nuns hospitals. And I just finished my critical care ultrasound fellowship with Dr. Buchanan, Dr. Lau, and Dr. Lux and Dr. Allerbish and the team. And I'll be talking to you today about fluid responsiveness and tolerance in critically ill patients. And so before we begin, I have no disclosures to report. I don't receive any money from any companies or equipment for this. The goals of today's talk are to talk about and define fluid responsiveness and fluid tolerance, to review static and dynamic measures of fluid responsiveness, and then to discuss the role of POCUS and bedside ultrasonography in fluid responsiveness and fluid tolerance. And so volume status is a very complex issue. There's been a lot of discussion about this clinically in the literature, in the research as to how we present it and what it means. So the terminology that we'll present here is a few things. The first is volume depletion, which refers to the loss of sodium and therefore free water from the extracellular space. Dehydration, which refers to loss of intracellular water, leading to desiccation and increased plasma sodium. Fluid responsiveness, which is defined as an increase in stroke volume of 10 to 15% after a 500 cc crystalloid bolus over 10 to 15 minutes, for which the definitive test is a fluid challenge. Fluid tolerance, as defined as the degree to which a patient can tolerate fluid. And then fluid overload, which is a state of global body accumulation of fluids, which leads to impaired organ function. For those of you who remember going through this in medical school and residency, this was the Bible for how we assessed patients for their volume status and their volume responsiveness and their fluid tolerance. And it was the rational clinical exam out of JAMA. Is this patient hypovolemic? There's a few other articles, but I wanted to highlight this one. And so this is based on all the studies that were done of physical exam findings and historical review of how to determine whether a patient who has hypovolemia not related to blood loss, whether it's diagnostic or not. And so multiple different studies looked at different investigations, and you can see on the right side for likelihood ratios, there's really no good physical exam finding for you to see whether someone has hypovolemia. And again, hypovolemia does not necessarily correlate to fluid responsiveness, but the poor quality of these physical exam findings further highlights the need for more information and a different approach to our care of patients. The best physical exam finding for hypovolemia, of course, is a cap refill with a likelihood ratio of 6.9. But it was defined as cap refill greater than the age upper limit of normal. And so you had to remember how old your patient was, what the upper limit normal was, and then how they looked compared to that. And if it was absent, it still did not rule out hypovolemia. And so we need a better way. How do we determine fluid responsiveness? There have been many tests proposed to determine this. Statically, we've used things like heart rate, as in tachycardia, blood pressure, low blood pressure, cap refill, urine output, collapsed veins. We've used CVP, a delta in the CVP with position or respiratory variation. We've used wedge pressures back when we used to do PA catheters in patients more frequently. We used x-rays to rule out pulmonary edema. We used lactates, mixed venous oxygen saturation. We've used pulse contours of the cardiac output. And the big one that we've talked about is the IVC size and variability. And that's been kind of a major focus of a lot of the work that we do, and a common question that we look at on POCUS. And so I'll talk briefly about the IVC. This was presented in a much better fashion by Dr. Baker on the ABSONA website. But in brief, the IVC is a complex issue, and it is it's been investigated at length in multiple different approaches. There's been some data to show that it correlates reasonably well with a CVP or right atrial pressure in certain populations. And so what we've done is we've used the IVC diameter and the IVC collapsibility with respiration in spontaneous breathing patients to estimate a mean right atrial pressure and therefore a mean CVP and an overall state of the degree of venous filling of a patient. And so the cutoff we use is 2.1 centimeters, and then the collapsibility of more than 50% or less than 50%. And then we talk about ventilated patient, which is a totally different population. And so in ventilated patients, the IVC can be normal anywhere from 1.5 to 2.5 centimeters, unlike the 2.1 cutoff we use in spontaneously breathing patients. A very, very small IVC suggests volume depletion. A very, very large IVC suggests volume overload. However, in addition to the size of the IVC, we also have the collapsibility. And so if you have a small IVC that does not collapse, your CVP will be different, or your RAP will be different than it is if your IVC is small and collapsible. And as we look at how the IVC changes with size and collapsibility, there's been suggested estimates of right atrial pressure. And then we look at a different paper and a totally different set of parameters is presented. And a second paper looking at the IVC then looks at change in diameter from expiration to inspiration, and a change of 25% suggests likely fluid responsiveness with a likelihood ratio of only 4.5, which again is not as good as the cap refill we saw on the previous slide. And all these studies looked at the IVC and then had terms like consider fluids, consider vasopressors, without really great guidance as to what we can do. And so what this means for us and for our approach to IVC is that there's really no great parameters that we can use for the IVC to definitively say a patient is or isn't fluid responsive. And there are multiple technical limitations. And so when we're looking at the IVC, we need to look at where we're measuring. It needs to be 1 to 2 centimeters from the cavo-atrial junction. Are we perpendicular to the IVC itself? Are we foreshortening it, or are we off axis? Are we eyeballing it, or are we measuring it quantitatively? How does someone who measures the same IVC compare to us? And the answer is poorly. And are we looking at the aorta or the IVC? And to this day, when I do echoes and abdominal ultrasounds, I still sometimes need to take 5-10 minutes to make sure I'm seeing the IVC instead of the aorta. And the only definitive way to see that is if I can follow the hepatic vein and I can follow the IVC into the RA. Otherwise, there is a chance I could be seeing an atypically looking aorta. And then in addition to technical factors, we talk about confounding factors. And so from the thoracic perspective, we talk about the magnitude of respiratory effort. Are they taking massive volumes? Are they paralyzed on a controlled mode at 6 mils per kilo? How much support is the vent providing? How much are they breathing spontaneously? And what is the change in pressure thoracically? And these are all things we can track, but can't correlate specifically to each breath. Then we talk about cardiac factors, and we talk about the RV function and dysfunction. Is this an RV that has underlying TR or pulmonary hypertension or other changes that would affect our ability to interpret the IVC? And then we go to the abdomen and we talk about things like ileus, where we can almost never see anything, or abdominal compartment syndrome, where everything's being compressed from high pressures in the abdomen. And so what is our takeaway from the IVC? In spontaneous breathing patients, we don't have any great data for fluid responsiveness, but we do have data for right atrial pressure. And so we can correlate in patients who don't have other confounding factors, the IVC as a surrogate measure of CVP or RAP. In mechanically ventilated patients, we've got some data, but it varies based on the study, and there's no cutoffs or thresholds known. There are lots of gray zone measurements that don't effectively measure the impact of the IVC, so I don't really use it. So my takeaway from this is that the way in which we use and get away with the IVC is we use it like a CVP. A fluid bolus in a patient with a very low CVP is unlikely to cause harm. If I tell you a patient has a CVP of 2, most likely you're going to feel comfortable giving a bolus, and you will almost certainly not see any negative effects from this. And then our feedback from fluid responsiveness is we go to the bedside nurse or whoever was there and ask, did the fluid help? And they say yes or no. And we don't really do a good job of revisiting the physiologic parameters that led us to give fluid in the first place. And so we then justify our fluid bolus saying the nurse at the bedside thought that the patient responded, they responded, we did good. Jumping back to fluid responsiveness. As we said, it doesn't refer to the total body water or sodium of a patient. It addresses whether fluid given as additional to the patient will increase cardiac output. And so this is our definition. It is a dynamic variable. It needs a dynamic test. So how do we predict fluid responsiveness? The two dynamic tests that exist are the passive leg raise and the end expiratory occlusion test. But doing the test is not enough. We need to measure fluid responsiveness itself. And so how do we do that? We can do it through a pulse pressure variation. We can try it through IVC. NICOM has been tried, carotid Doppler has been tried, and end-tidal CO2 has been tried. I'm going to highlight echocardiographic VTI. That's the velocity time integral. And I'll tell you a bit more about that in a second. This is when available, this is the best way for us to assess fluid responsiveness in patients. The test. So this is the passive leg raise. It's quite straightforward. You start at 45 degrees. You gradually lay them down without trying to cause stimulus that wakes them up, changes their adrenergic surge, or changes their peripheral vascular resistance. Then you raise the leg and then you set them back up. And you will see on your measurement some change in cardiac output of at least 10 to 15%. And if you see that change, you can then give fluid to confirm your fluid responsiveness. What is end expiratory occlusion? I'll be honest, I don't do this. So this is an expiratory breath hold of at least 15 seconds. Very few of our patients can tolerate a long expiratory pause. If we're looking to see, are they in shock? Do they need fluid? Oftentimes they're hemodynamically unstable. They might be acidotic. This is an ideal world test, one that I don't like to use because it requires manipulation of the patient's pulmonary physiology and may affect their ventilation in an already tenuous situation. And so at the end of the 15 seconds of pause, you can look and see your measure of cardiac output should have improved by at least 5% to correlate with fluid responsive state. And so what is the LVOT VTI? So it is a measure of the amount of blood flow through a point on Doppler using a point of care or a comprehensive echocardiogram. It's performed in an apical 5 or an apical 3 chamber view. And what you do is you place the pulse wave Doppler at the LVOT and measure it over one beat or one period of stroke volume. It is a surrogate marker of stroke volume. So for those of you who remember, stroke volume is the amount of blood flowing per point over the total area. And so if we know the LVOT area and the amount of blood flow per beat through each point on the area, it's area times volume, you get the stroke volume per beat. And this tracing is the integral, which is the amount of blood flow through that point. And so what we do is we optimize our patient, get our apical 5 view, confirm we have it in a upright and a supine with leg raised view. And then we prepare to record it with those two things, looking for a 10 to 15% change in the VTI with straight leg raise or with end expiratory occlusion. What I have for you here is an example of two different waveforms which look and see how the VTI changes with a straight leg raise, or sorry, passive leg raise. And this is a effective and safe way to determine fluid responsiveness in patients who are not strict C-spines, who are also not doing anything else. Great. So we determined the patient fluid responsive. Let's give some fluid. We're ready. Not so fast. We still don't know if that fluid is going to cause any harm to this patient. And so what is fluid tolerance? This is an emerging concept from the literature. And it has to do with an understanding of the impact of further fluid on a patient's end organ function. And there's been many papers about this and many different definitions in the literature. And this is still an evolving concept, both in terms of quantification and impact on our clinical care. And so one of the things we look for when we talk about is giving fluid going to cause organ dysfunction. We talk about pulmonary edema, elevated left atrial pressure, RV dysfunction, and then venous congestion, such as hepatopathy or renal failure. And there is a fluid tolerance spectrum that we talk about in ICU. We believe someone is fluid responsive to a point, and then shortly after they become fluid intolerant. They can often be tolerant a bit more than they are responsive. We hope that they'll be tolerant right up until they're responsive, and then we know right away we've given enough fluid. However, what we often find is that someone may end up improving their cardiac output with further fluid, but that fluid may cause pulmonary edema, congestion, or other signs of organ dysfunction, in which case the degree of tolerance, or the point at which the patient stops being fluid tolerant, is actually earlier than they are no longer fluid responsive. And ultimately, what we see is that these parameters change for a patient. A patient may not be fluid responsive or fluid tolerant one day and then be fluid tolerant but not responsive another day, depending on how the capillary leak, glycocalytic damage, oncotic pressure all changes with time and with treatment of the underlying process. And as organ dysfunction may get better or worse, that degree of fluid effectiveness will change as well. And this is an evolving measure that we really don't characterize over a period of a few days, but certainly is something that is an issue. And so I'll touch briefly on elevated left atrial pressure. This is not something for us to address here. This is more of a comprehensive echocardiology assessment. But just in briefly for us to know about diastolic dysfunction, because it is a measure of end organ dysfunction and fluid tolerance, we look at a few measures in normal LV function patients. We look at an E to E prime ratio, which is a ratio of the E wave across the mitral valve with the tissue velocity across the septum and the lateral wall of the left ventricle. We talk about tricuspid regurg velocity, and we talk about big left atrium. And across these parameters, we look and see, is there diastolic function normal? Is it diastolic dysfunction? And offline, I can talk to you, all of you, more about this individually. For the purposes of the way in which we do things in ICU, I don't generally ask that my intensivists or trainees do this. There's simply too many variables and too many difficulties obtaining the right images to be able to effectively capture this. And it's confounded by the fact that when we look at patients with depressed EF or regional wall motions, the actual algorithm for dysfunction or diastolic dysfunction and elevated left atrial pressure changes to include EA ratios, which looks at passive filling across the mitral valve compared to the atrial kick and atrial flow. And I'll suffice it to say that this is something that for advanced practitioners provides some value, but is not something I would expect anyone to do when doing point of care ultrasound in the ICU. And so when we talk about fluid tolerance or intolerance, what are some risk factors? Well, the non-modifiable ones are age. With increased age comes a lower fluid tolerance limit, comorbidities such as chronic pulmonary disease or structural heart disease, and the severity of initial circulatory dysfunction. Do they have some severe dysfunction in terms of glycocalyceal damage, oncotic membranes, things like that? And then with regard to illness-related factors, capillary leak, inflammation, endothelial damage, and then adequacy of initial resuscitation. We know that effective early initial resuscitation improves outcomes compared to not. And looking at assessing fluid tolerance, we talk about a few different things on ultrasound. And I'll bring these to you because this is what I do when I'm doing my point of care scans. I look at B-lines, pleural effusions, and elevated left atrial pressure when I'm looking at the pulmonary system. I look at the LV and RV size and systolic function. I look at the septum, whether it's D-shaped, whether there's any bounce. And I look at diastolic dysfunction. From a GI perspective, I look at the portal vein and hepatic vein Doppler flow, and we'll talk briefly about that. And then from a GU perspective, I look at oliguria and renal vein flow. And the more specific we get with particular vein flows and waveforms, the more likely we are to make errors and misinterpret the data we have. And so I really look more broad strokes at, do I see objective signs of volume overload causing dysfunction? And that leads us to VEXUS. And so VEXUS is the concept of venous congestion in ultrasound. It's used in conjunction with the IVC to assess the degree of congestion in the liver, gut, and kidneys. We do 4 measurements for this. We do IVC size, we do hepatic vein flow, we do portal vein flow, and we do renal vein flow. These are Doppler flows, and we trace the waveforms and compare them to what we expect the normal to be. This initially came out of Montreal and was validated in critically ill cardiac surgery patients as a risk factor for acute renal failure. And we've now begun to extrapolate it towards fluid tolerance and fluid effects on the body. This is a figure that is available online from POCUS 101, and it presents the 4 different measurements we do for VEXUS, as well as what they look like. And so the excluding factor is an IVC diameter. Your IVC must be more than 2 centimeters for you to have any congestion based on VEXUS parameters. If your IVC is small, you can move forward. You don't need to worry about congestion. If it's more than 2 centimeters, you then go and measure your hepatic vein, your portal vein, your renal vein. And so the easiest vein to visualize for early practitioners is the hepatic vein. It tracks directly into the proximal IVC. It can often be seen both in a parasagittal view and a lateral view. And it has a very particular waveform. So it has a deep negative systolic wave, which is flow back to the IVC, followed by a small negative wave in diastole, and then a small positive wave at the end of tricuspid valve closure. And as the degree of congestion increases, the diastolic flow actually reverses, and ultimately you get a full S wave reversal where you get positive flow during systole and then negative flow in diastole. And then across the portal vein, we look at what is the pulsatility index. How much does the portal vein vary from min to max with respiration and with heart rate. And then finally, the renal vein, which is the most challenging and oftentimes very difficult to assess. I've been able to catch it in approximately 30 to 35% of my scans. And so I expect this will be a very difficult factor to assess. But when looking at this, we look at going from continuous flow to discontinuous flow that goes from biphasic to monophasic over time as the congestion becomes worse. And so we grade congestion severity based on the amount of congestion and the number of abnormal waveforms we see. So if we see severely abnormal patterns of any kind, we have at least grade 2 congestion. If we see at least 2 severely abnormal waveforms, we go to grade 3 or severe congestion. All of these require an IVC of more than 2 centimeters. And we then want to look at least 2, if not 3 parameters to make sure we capture this. And so that's a lot of jargon to jump back and ask, what's my approach to fluid tolerance? I have trouble with getting these waveforms effectively in all positions. So what I do is I look for end organ dysfunction. Do I see diffuse B lines with pleural effusions? Do I see a massive IVC with no variability? I will try and get the portal vein. I'll try and get the hepatic vein. I'll look at urine output and signs of venous congestion. I will use a CVP. There are no great validated measures to say that a patient is or isn't fluid tolerant beyond the combination of clinical assessment as well as findings of volume overload on examination and on point of care scan. It ultimately becomes a clinical decision. I find that in patients who show signs of volume overload, that's been my threshold to hold off on further fluid and change my vasopressor inotropic support to further than hemodynamically optimized patients. And so my takeaways from this are, as we move towards moving POCUS to a regular part of every ICU admission and every assessment, be specific about what you are looking for. Are you looking for LV function because you're worried about cardiogenic shock? Are you asking about fluid responsiveness? Are you worried about fluid tolerance? Are you worried about hypoxia? Those are different questions that require different tests and different exams. A patient can be fluid responsive, tolerant, both or neither. And this can be independent of their volume status. There are patients who have 2+ edema who will be fluid responsive, fluid tolerant, because their edema is not related to their intravascular or end organ status. A passive leg raise with the VTI measured pre and post is the most effective way to measure fluid responsiveness. And then end organ dysfunction is the simplest way to find evidence of fluid intolerance. The IVC is a great static measure of CVP in certain populations. I do not use it to predict the effect of an intervention. And with that, I'm happy to take any questions you may have. I'm actually going to try and change to my other machine here so I can hear questions.
Hi, Les. Can you hear me?
Yeah, I can hear you.
Wonderful. Absolutely brilliant talk. Thank you. You know, these parameters that we use to look for fluid tolerance is all, my understanding is hemodynamically, it's all basically just looking at, you know, end diastolic pressures or indirect markers of end diastolic pressures. Now, one thing that you did mention, which I hadn't actually thought of before, is, you know, the disease state that the patient might find them in, like, you know, the inflammatory response, leaky endothelium, et cetera. Did you come across anything to try and predict that? Are there any like predictive scores or so? Because that certainly uncouples, you know, a heart that is functioning well on a Starling curve, you know, considering fluid responsiveness to how well they're going to tolerate it. Did you come across anything like that?
What I've encountered is that there's too much heterogeneity in the population, and there's also changes in the myocardium as well that have been characterized across septic states. So there's been some early attempts to try and characterize this, but there's been no validated study which says that certain types of ICU-related diagnoses or admissions, whether for sepsis or for ARDS, have different effectiveness. I think ultimately the key message here is that with increased permeability, your tolerance will change, and the dynamic measures of diastolic function will actually change over time. And so the patient's diastolic measure, which was done on echo 3 months ago, may not be anywhere near what their heart can tolerate at present, if that makes sense.
Yeah, no, it does. And yeah, as you mentioned as well, diastology and so on within the critical care population is I don't know, difficult, crapshoot, whatever you want to call it.
Excellent. Thanks, Leon. Dr. Katsiganis?
Yeah, that was a great talk, Laz. Having lived through like the Swan-Ganz and all these different measurements, we used to use a venous return curve in the RV to target fluid responsiveness. Has anyone looked at actually looking at, it's a dynamic measure, looking at venous return curves, like measuring pressures via CVP? In the past, it was with the Swans and CVP, and the trajectory of that against the ultrasound IVC measurements, because I mean, it all depends on the function of the RV, and many of our patients don't have normal RV function, right? So I don't know, I haven't looked at these studies, but how many are with normal quote unquote patients versus patients with RV dysfunction of various types?
Yeah, that's an excellent question. So interpretation of waveforms across both the CVP and then hepatic vein is the other one we look at commonly in terms of progression over time and with respiration has been looked at. And the truth is that it's still just a static measure. And one of the things that I want to stress and that I encountered in the literature is that any static measure will not help us determine volume responsiveness, short of a truly low venous return state or a truly high venous return state. The middle area where you've got kind of a middle ground CVP, middle ground waveform, middle ground IVC is difficult to interpret in the setting of RV dysfunction, ongoing ventilation, positive pressure, those kinds of things. So the movement in the research so far has been towards quantifying dynamic measures, and the leg raise has been the safest one that we've found. There's no great other measures that we can use, but the waveform stuff that's been done is useful for, again, predicting kind of venous filling states, but doesn't help us with volume responsiveness in the sense that the current degree of volume doesn't predict the next 500 cc's, or at least so far no data has proven that. Does that make sense?
Sorry. Yeah, that makes sense. Have they actually plotted the IVC changes against the curve, not just a static measurement, against the IVC return curve? And secondarily, how can you measure dynamic changes without measuring some degree of resistance of the peripheral circulatory system? Because that's dynamic as well. Seems very complicated to me.
Yeah, you're completely right. And one of the big limitations is you can't predict that there will be SVR changes with changes in position. And certainly a patient may wake up more, their medications may change, they may require more sedation, or even you bump the bed and their situation changes. Those are all things that do significantly affect the measurement. I've not seen any IVC to CVP flow tracings directly. I don't know if Leon or if Brian's still here, whether they can comment on that. But that's a very good question as to kind of some of the work that I've not encountered in my literature search.
I guess the way I see it is all these measurements help in their own little way. And you tend to, I imagine you combine all these pieces of information to get to a true state, right?
That's exactly it. I think that there is no one point that I use to determine fluid responsiveness or fluid tolerance. It's a global assessment of the patient and using the kind of the best parameters I have available. If a patient is normotensive with normal renal function and is on minimal respiratory support, but they have a 15% change in their cardiac output with a passive leg raise, I'm not going to give them fluid because I don't think they need it. But certainly they may be fluid responsive should they require it in the clinical context. And as you alluded to, this is still a clinical assessment of a patient, and the POCUS scan is really just a way for us to further validate and justify our decision making. It is not the decision that we are making.
Thanks, that's useful. It'd be interesting to see, like after measurements, if we have people with CVP lines in, doing 3 or 4 boluses and looking at the change in pressure over like and plotting, because it'll plateau eventually, right? And that'll give you the plateau of the curve, and the RV should technically be filled. But anyway, just a thought.
Absolutely. Thank you so much. Any other questions at present?
Thanks, Les.
You're very welcome. So I guess with that, we'll wrap up these rounds.